Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network Home Health Kickoff Webinar. Your host, Andrea Lahoff, will begin.
Good afternoon or good morning, everyone, based on what your time zone is in, and welcome to today's webinar presented by the Lake Superior Quality Innovation Network. My name is Andrea Lahoff, and before I introduce today's speaker, Cindy Sun, I'd like to just give a brief overview of the QIO program and our assistance to home health agencies as part of our cardiac initiative. Last August, CMS changed the structure of the QIO program from state-based to regional. There are now 14 regional quality innovation networks, quality improvement organizations, also known as QIN-QIOs. Lake Superior QIN is comprised of 3 organizations: MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota. And we are here to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. QIN-QIOs bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, and improve clinical quality. QIN-QIOs are skilled in creating opportunities for providers to learn from each other by applying advanced improvement and analytical methods, engaging patients and families, and structuring processes for sustaining positive change. And our funding from CMS started last August of 2014, and it will run through July of 2019. So the Lake Superior Quality Innovation Network is working on 8 programs covering a wide variety of areas and settings. And some of these examples are on your screen, and these include improving cardiac care, which is the program we will be talking about, improving diabetes and access to DSME workshops, immunizations, electronic medical records, and health information technology, improving the transition between care settings, assisting providers with quality reporting, reducing infections in hospitals, and improving the quality of life for those in nursing homes. So for the improving cardiac health and reducing disparities, specifically for home health agencies, our initiative is focused on measuring the progress of ADCS measures in cardiovascular health, which is aspirin as appropriate, blood pressure control, cholesterol management, and smoking cessation. So there are many benefits to participating in our program, and these are listed on your screen. Okay. There we go. And just a few benefits of participation. You would have access to tools and resources, including admission to webinars and conferences. We would be able to assist you with the Cardiovascular Data Registry, which Cindy will speak more about, and access to best practices and other learning sessions. So the Lake Superior QIN is partnered with HHQI by using best practice intervention packages developed to reduce heart attacks and strokes within the home health setting. So we also have a new initiative in the state of Michigan. On April 15th of this year, MPRO of Michigan was awarded an additional task order which focuses on improving the assessment and documentation of Medicare beneficiary immunization status, increasing overall immunization rates, and reducing immunization disparities. And we are able to work with home health agencies to improve immunization for influenza, pneumonia, and shingles. And you can see there are many benefits of participation in this program as well. So if you are interested in also participating in our immunization initiative in Michigan, please feel free to reach out to your MPRO coordinator. So now I would like to introduce you to today's speaker. We have Cindy Sun, the lead cardiovascular health project coordinator for the West Virginia Medical Institute Quality Insights, which is the QIN-QIO for the states of West Virginia, Pennsylvania, Delaware, New Jersey, and Louisiana. She has worked on the CMS HHQI national campaign since 2009. Her primary responsibilities include assisting with the integration of preventative cardiovascular care into the home health setting through the development of educational resources as well as the Home Health Cardiovascular Data Registry. So at this time, I would like to turn it over to Cindy.
Thanks, Andrea, and hello, everyone. such a pleasure to be here today, and thanks for inviting me and having an opportunity to meet with you. I know it's a little better if we meet face-to-face, but in our virtual world, this is the best we can do. So I thank you for taking the time to join, and I hope to share some information that you'll find beneficial. So we'll go ahead and get started with just, after we finish, I hope that you'll be able to see the quality of implementing cardiovascular care into your quality improvement plan, as well as being able to access the HHQI tools and resources, and then also maybe come up with 2 or 3 of the tools and resources that will impact your patients starting as early as tomorrow. So just a little bit of history about this cardiovascular initiative that Andrea was talking about. You know, it all started when you look at statistics, and I realize we're all a little overwhelmed with statistics, but these are kind of catching to me, especially the bottom right-hand corner. You know, we are a developed country, and as a developed country, to have a racial disparity in life expectancy of a disease that is, for the most part, controllable, not 100% preventable or controllable, but in many cases, with simple changes and simple medical management, these symptoms and life expectancy could be the same across the board. But the fact that we have such a racial disparity in this, and we consider ourselves a developed country, I think that's a little staggering. So for this reason, as Andrea was mentioning, the Million Hearts Initiative was created. And if you're not familiar with the Million Hearts Initiative, this is something that the Health and Human Services, that particular section of the entire government, asked co-chairs of CMS and the CDC, Centers for Disease Control, to co-lead the Million Hearts Initiative, and with the overarching goal of reducing 1 million heart attacks and strokes within about a 5-year period, and that's focusing on the ABCSs, as you see here listed on the screen. So they came to HHQI and asked if we could help integrate this information into a home health setting. So if you're familiar with HHQI, what we do is create educational tools and resources that are, of course, free and evidence-based. And we created 2 of the best practice intervention packages titled Part 1 and Part 2 of Cardiovascular Health. Part 1, very simply, focuses on aspirin as appropriate and blood pressure control, and Part 2 focuses on cholesterol management and smoking cessation. Now, these are filled with tools. Here you can see clinician and patient fact sheets. Of course, you cannot read these. I'm just showing them to you to give you an image. But you can see what we're looking at here are the clinician fact sheets simply because of all the wordiness of it. But there's also patient fact sheets that you can see here, where the patients can use them for interventions and taking them to and from their physician's offices. There's multimedia tools that are really incredible. We did not create these. What HHQI does is we collect all of the evidence-based tools and resources, put them together, and then send them out to a technical expert panel of anywhere from 20 to 50 people around the country who are experts in either home health or experts in the field of that particular best practice intervention package, in this case, cardiovascular clinicians and physicians. And so of those, they trim down which tools and resources they consider to be the best. And that's what's available on the website, so that you don't have to go to all the different websites out there and collect them yourself. The video on the left, it says right there, it's a 3-minute video by Mayo Clinic. This is a fantastic one to help your patients understand what it is that you're trying to do when it comes to hypertension, or what the vascular system has to do with heart disease. Very simple. And the reason I'm showing this is so that you'll understand they're available and you don't have to recreate the wheel. And let's say that your clinicians do not have the capability to either run that video in the field. Possibly they could do the PowerPoint on the right-hand side, which I'll show a little bit later. This is a PowerPoint presentation it has phenomenal pictures, and it has the text or the speaker notes on the side, so the clinicians can either read that or they can read ahead of time and know what to speak over top of it, so they can show the pictures and be able to educate the patients and their families very quickly, very rapidly. But again, they don't have to recreate the tools. One tool that we do include, and it was too small to see on the clinician handout I showed earlier, and this is throughout the DPIP as well, is to help with clinician buy-in. And you may be aware of this, but when we started, And I must tell you, when I was first told we wanted to focus on aspirin, blood pressure, cholesterol, and smoking in home health, I think I had the same reaction as many of you. Blood pressure, really? Seriously? This is something that's done all across the board. But really, once we started diving into it, I had my ego knocked down quite a few points because I did not know anything. I really thought I did. I'm an old clinician, but I didn't. So I've learned a lot, and this is one of the things that was most eye-opening to me, that with the reduction of blood pressure by 5 millimeters of mercury, you can read the statistics on the screen. 14% overall reduction in mortality related to stroke, 9% reduction mortality related to heart disease, and that one at the bottom, 7% decrease in all-cause mortality. That means all of our patients who happen to have hypertension, if we reduce their blood pressure, if they're above the 140/90, which is the highest controlled pressure for those who do have the diagnosis of hypertension, if we can reduce their systolic by 5 millimeters of mercury, these are the statistics we'll get. So we're not talking about taking a patient from a 180/100 blood pressure down to a 140/90. We're talking about 5 millimeters of mercury. Then it comes up to the question of, what about assessment? How exactly are we supposed to take blood pressures? Now, we've had this question from across the board, and there are multiple tools in the BTIP that will help with this type of this answer. And one thing we have found is when it comes to blood pressure assessment, there are really two schools of thought, and your agency will probably subscribe to one or the other. One is every clinician who enters the home takes a blood pressure. And the attitude is usually, well, yeah, duh, of course we take the blood pressure. Then the other school of thought is we have certain disciplines that do not take the blood pressure in the home, and they will not take it, they are not to take it, and it's not in their scope of practice. And again, well, duh, it's not in their scope of practice, so we're not going to have them take it. Now, I'm not picking on people, but one that we've heard is a common theme is there are many therapists in the country who are not taking blood pressures. And to the point that it caused us to kind of take a step back and say, wait a second, we never want anyone to practice outside of their scope of practice. So we approached the APTA, the American Physical Therapy Association, and to make sure, is this within taking a blood pressure, is that within the scope of practice of a physical therapist? And we were very apprehensive because that's not anything we ever want to do. And the APTA said, of course it is. What has happened is therapists over time, and again, there is a definite divide. So if your agency, all your therapists are taking pressures, that's wonderful. But if your agency is one that is not, there are a couple resources available on the HHQI site. We've had a couple of different webinars recently. One was in January and one was last month, where representatives of the APTA who are actual therapists and are actually home health leaders in their own organizations came on and talked about different methods and ways to approach that. But the reason I'm going on about this is to say that if you are at the school where your therapists have not been taking pressures and you're going to begin requiring it, it's not something they're going to probably be able to go right out and do. So if you're not already, you may want to consider putting vital signs, but especially blood pressure assessment, into your annual competency assessment day or days or week, whatever it is that you hold for your annual competencies, and to ensure that everyone is taking them correctly. And if you have someone who has a skill, think back. If we learned a skill 15 years ago and we haven't performed that skill in the past 15 years, we're probably not going to be very efficient. So this is something that it may take some relearning and just some quick educational days to make sure that everyone is knowledgeable of how to take pressure and that they are doing it accurately. So there are different video clips as well as different tools and resources in the BTIPs that will help with that, as well as the orthostatic hypotension. Okay, realistically, in home health, not all of our patients are going to be able to stand for 3 minutes and do the standard, typical orthostatic posturing. But understanding the way it should be done is necessary so that the clinicians can chart against it. If they're not able to do the orthostatic pressure readings according to what is the standard of practice. That way they'll know how to chart and what to say as far as why it was not completed accurately. So just making sure everybody's on board and aware of these very simple, basic skills. Now this is the video I was mentioning. You can see the PowerPoint slide on the right, and it says video there, but it's actually the PowerPoints where the clinician can read the notes on the left and speak over top of it. You'll notice that the visuals are just great. Let's say you want to focus on smoking. Maybe you have a high population of tobacco abuse. If so, the American Heart Association has the 5-step process that you can implement if this is something that is interesting to your agency. Remembering, each of the BPIPs is just full of tools and resources, but you want to really narrow your focus down to probably no more than 2 or 3 tools that you want to implement at one time. So we put everything out there for all 12,000 agencies to select from. But understanding you don't want to jump in, or you could be minus a bunch of clinicians, which is not what you want to do. So anytime we change anything in home health or any healthcare setting, and we implement any tool or any resource, we need it to be data-driven quality improvement. We need the evidence to support why we're doing what we're doing, and that is through data collection. Well, understanding, all of us that have completed OASIS in our lifetime, we've realized although the OASIS is very good and it serves its purpose, it does not collect really anything on the ABCSs. Instead of agencies having to filter out which patients and which ICD-9 codes have to go in and what each patient should be held accountable for and all this, at HHQI, we just created something called the Home Health Cardiovascular Data Registry, or the HHCDR. Now, again, some of you may already be participating in this. Some of you may have heard of it, and some of you may be saying, what is it? So I wanted to just take a few minutes today and share with you what it is and maybe help answer any questions that you may have with that. So we're focusing on the ABCS data. Now, those of you that have participated in registries in a hospital or facility, you're going to look at this, and I'll warn you ahead of time, you're going to think that this is way too simple, because it is, and that was intentional. This registry is going to collect the bare, basic information that is necessary to evaluate, so you can evaluate how your plans and how your quality improvement is, how it's coming along. So on the aspirin, we're looking at, was the patient taking aspirin or other antithrombotic? Blood pressure? What was the patient's final blood pressure, and was hypertension addressed during this episode of care? For cholesterol, did the patient have a lipid screening in the past year? And if so, did an LDL-C get done, and if so, what was it? Smoking, was the patient screened, and if they were screened for tobacco use and were found to be a user, did they receive any type of smoking cessation counseling or any type of pharmacotherapy? Remembering that when we talk about smoking cessation counseling, we're talking about a 3-minute session. We're not talking about a 6-week or 8-week course. 3-minute counseling session sometime over that episode of care, that's all it's required to be a yes. So to get to the registry, you'll see, you go to the HHQI website, which is www.homehealthquality.org, and you'll see the word data on the blue toolbar, and you'll click that. Now, while we're on this, I will just point out on the right-hand side, you'll see the words log in and register. That's how you would log in and register to access really everything having to do with HHQI except data. That login and registration will get you to under that education tab, that's where you find the BPIPs. It will get you to the webinars and really about 98% of everything HHQI related. But to get into the data and the registry, you click the word data on the blue toolbar, and that'll take you into the data portal. And here you will see a different login and registration. And this is the one that you would secure. It's a secure website to get into your data. The previous website is open to everyone, including all of your patients and families. There is nothing secured on that first page. But this part is secure, and it's a little tough to get into, but once you're in, you're in. Now, while we're here, I will just mention on the right-hand side, you'll see data resources, and this is where you'll find the step-by-step manuals and webinars. you'll find some of the same information as well as many other tools and resources that are out there to help you with the process of implementing progressive cardiovascular care into your quality plans. So once you get into the registry itself, you'll be asked what year and month of discharges you'd like to abstract. The very first option that you have is if you were reporting to CMS in July of 2014, those discharges would be your first option. Anything before that is not in the registry. Now, the registry runs about a month and a half to 2 months behind of the actual discharges. So right this minute, as of a few minutes ago, the registry was just updated with the March discharges. So your patients who were discharged in March are officially up there. Click the word abstract and it takes you into the registry, and here's where you get to select. Each month, every agency has this option. The very first time you enter it at each month, you'll be asked which of the topic areas you wish to focus. Would you like to focus on aspirin or blood pressure or cholesterol or tobacco or all four? Every month, you can change them from month to month and jump around. Many people go in at this thinking, I'm going to show you how simple this is, but many people, of course, still don't believe it, and I'm not sure that I would believe it was that simple either. And so they'll start off with the easiest, which is usually aspirin or blood pressure or smoking. And then after that, they advance into other topic areas just because it's a little, once you feel, again, I can relate. I'm not so sure I would believe it was as simple as all of that either until I actually saw it. So you use these drop-down check boxes, check which topic area you want, and like I said, each month you change from topic area to topic area if you choose. And then you click Save Settings. Here, you will see your actual registry. Now, going across the top, you'll see the topic areas, the column headers of what that information would be showing under that blue box. The blue box would not be there on your screen. Each of those rows would have a separate episode of care, and it would include the patient ID, the start of care, and discharge date. And click the little word Edit. Difficult to see on the screen, but that says Edit, and it's a hyperlink. You would just click that next to the episode when you're ready to go, and it will take you into this episode. On the right-hand side, I've blocked out most of that information because it is PHI, but you can see all of that is preloaded from your OASIS that you transmitted to CMS. You do the work. You go in the home, your clinicians complete the OASIS, it gets transmitted to CMS, CMS releases it to us, we separate out the patients based on their ICD-9 codes and what is on the OASIS. That's an important thing to remember because let's use the example of hypertension. Most of our patients in home health have 15, 20 diagnoses, and the OASIS does not have that many slots for the ICD-9 code. So whatever codes made it to the OASIS is how these patients in the registry are separated. If hypertension made it to one of those coveted spots on the OASIS, then that patient would be listed under diagnosis codes about 8th row down and would be in the hypertension category. The way this works is that initially, each topic area that you select, there will be 12 randomly selected episodes of care for that to qualify for that topic area. So if you select one topic area, I'm going to just take blood pressure because that's what we're talking about here. Let's say you selected blood pressure. You would open up the registry and see 12 episodes of care who had the diagnosis of hypertension and qualified for that episode. You do not have to randomly select them. The system does that for you. And the reason for the random selection, let's say you had 300 discharges of patients with hypertension, it's really just simply to prevent the hunting and pecking. It would be very simple or easy for someone to go in and say, I don't want to abstract on this patient because they really didn't comply. I don't think we met the goal on this one. No. We want to remove that so that it will add strength to your report. But it doesn't mean that you're locked into that. You open it up, there's 12 episodes. Let's say you only get 3 of them done in that month and you want to close out so you can get your report and see how this works. That's perfectly fine. You're not locked into anything. That's a really important thing to understand. So if you selected 2 topic areas, let's say you selected aspirin and blood pressure, well, then you would have no more than 24 episodes to abstract. And again, these are just suggested. Once you complete those 12 or 24, however many topic areas you selected, once you complete those patients that are listed, then all of your patients will populate and you can continue to abstract if you wish. But the magic number of 12 is simply there for the episodes to give you a stronger report. Now the question comes up, what if you're a smaller agency and you had less than 12 discharges that month? Does not matter, because again, that 12 is simply to remove the hunting and pecking option. So if you had 3 discharges that qualified for blood pressure, you abstract all 3, you have the strongest report possible because you just abstracted 100% of your patients. That's a lot of information, but I want to make sure that those of you that have small agencies do not misunderstand, because when you have a small number of discharges, this is a wonderful time to get in on the registry and implementing this. So as you continue to grow, and you will, as you continue to grow, you'll already have all of this in place. So once you're confirmed on the screen that you have the right chart in your hand, that's all this information is for. Like I said, it's pre-populated. You don't enter anything on here. So you've confirmed you have the right patient. Then if you scrolled on down, it's a different screenshot, but you would be asked the first question no matter what topic area you selected, and that is, was the patient eligible for both Medicare and Medicaid? Was the patient dual eligible? And if this is not something you're already identifying in your agency policies and practices, you may want to consider doing this for a couple of reasons. The main reason is patients who are dual eligible in our country have a very strong disparity in care, and that evidence has been noted throughout the literature. And for that reason, in HHQI, you will find multiple tools that are geared towards reducing the disparity towards the patients who have dual eligibility. The other thing, though, if you even want to go to a more practical side, and I don't know your state's definition of Medicaid definition of homebound status, but in some states, the Medicaid definition is a little looser or a little more freeing, if you will, than Medicare's definition of homebound. So if your clinician goes into the home, and you know we've all done this, you go in the home and you think you've got a 3-week gorgeous plan of care all ready and set for this patient, and you walk in and all of a sudden they just got back in from the store and they drove themselves. So you immediately have to do a discharge, which throws your plans out the window. So instead of doing that, if you know that your Medicaid definition may allow you to stay in under certain conditions that Medicare would not allow you, and if you knew as a clinician if that patient was dual eligible, that would allow you to continue with your normal plan of care and not have to stop abruptly and try to throw 3 weeks of teaching into that last visit and get out of there because you don't want to commit Medicare fraud. So for that reason, as well as when we have to discharge our patients rapidly, understanding about DME, does the patient do they qualify for any type of waiver assistance if we're no longer able to stay in there under Medicare payment? Knowing as a clinician and a case manager ahead of time if the patient had Medicaid and what they were eligible for may help with the discharge process to make it flow a little better. So anyway, that is the first question you're asked. Was the patient dual eligible? Yes or no? That's all you have to choose from. You don't have to supply numbers. You don't have to put them through the qualifications. It's just simply, were they dual eligible? And if you chose aspirin, you would be asked this one question. Did the patient take aspirin or one of the other antithrombotics? There's actually 4 options inside of the antithrombotic parentheses. This is an old shot. I apologize for that. And your options are yes, no, or it's contraindicated. And that's it. Now, if you selected blood pressure, you'd be asked to enter the systolic, diastolic, and the date that was obtained. That would be the last pressure in the record. And there's a drop-down calendar. And was anything done about the blood pressure during this episode of care? And it's simple. Yes or no. That's all. And you're done. If you selected cholesterol, was the patient screened in the last 12 months? If you selected yes, you have a checkbox of what parts of the cholesterol screening were done. Just check what applied. And if you checked LDL, you would be asked, what was the actual value and the date that it was obtained? And finally, if you chose smoking or tobacco, you would be asked again in drop-down menus, was the patient screened? If so, was the patient a user? If yes, did the patient receive the brief counseling or pharmacotherapy? Yes or no? That's it. Now, all of this, once you've closed out your month, around the 23rd of the month, you'll receive a report, and it will give you the indications of how your agency is progressing, and this way you can track the progress. So if you have not started any of the ABCS implementations, this is a really great time. You'll want to go and enter your data into the registry for a few months before you start the implementations. And like I said, you can go back to July of 2014 to do this because you want to have a baseline. So you want to have a good couple of months of data in the registry before you started the implementation. So let's say you're ahead of the curve and you started this in January of this year. You want to make sure that you have some November and December discharged episodes of care data in here so that you can have a baseline and you will be able to show your improvement. Now, do you have to do this? No, absolutely not. It's just a suggestion because the idea in quality improvement is we want to show how improved what we have done and how we got there. And this is data-driven quality improvement. This is also, if you have not already developed your quality plans for the COP, this is a strong one. We hear many agencies around the country are using this for their second or first quality plan for the COP because, as you can see, you have the data, your agency and your clinicians have the skill set. It's a fairly simple one, and the evidence is there. The tools and resources are already created for you. So, again, just keep it in the back of your mind when you are working on the COP. And, yes, I know it's not out, but we all know that that thing is coming, and it's going to get here. And if you haven't heard the National Association for Home Care and Hospice's quote on this, I think we're all in agreement that they've said it very nicely over and over that the COP, when it comes out, there's going to be many elements included in it. And I'm talking about the conditions of participation, if you weren't aware of the acronym of COP. There's many things that are going to be included, and there are many things that may change because it is already down from the time that it was put out for public feedback. But one thing is clear, data-driven quality improvement and quality plan development is going to be a definite. NOC is suggesting, as we are too, get your quality plans in place and to the sustainable level before the COP comes out. That way you'll have resources to put towards whatever other parts of the COP that are going to come out that your agency isn't already addressing. That gets the quality plans up, running, and sustainable prior to that so that you'll be ready for the rest. And now, before you ask, neither your Quinn nor us, none of us have an inside track. We don't know anything more than you do as far as when it's coming out. For all I know, it could have been published in the past hour, or it could be published a year or two from now. But either way, it's not an emergency, but it is something you definitely want to not play ostrich on this one. It is going to come, and the quality plans are a must. So hopefully, as you're reviewing this and you start to think about what it is you want your agency to focus on, and you narrow that focus down, if it does come into cardiovascular care, we want you to be aware that this is available for you, and you can easily turn it into a copy. All right, so this is the report, and it goes on multiple. I, again, just took a screenshot of the blood pressure report, but there is one for every measure. That would be every topic area of aspirin, blood pressure, cholesterol, and smoking. Now, a few details just to recap. You get to the registry through the normal HHQI data access portal. You, at the agency, will select which of the ABCSs you wish to focus each month. Demographic information is populated around the 15th of the month, and all data that's closed by the 14th of the following month. So let's use this month. It was populated May 15th, and it was closed. If you close it by June 14th, you'll get a report around June 23rd. So let me back up for a second. If you do not close it on the 14th, what happens? Absolutely nothing. That data will stay in there until you close out the month. We don't touch it until you tell us to. And you can find more details. There's a webinar called the HHQI Overview that will give you screenshots and how to navigate through the registry. Now, a couple more things I just wanted to share before we open it up for questions is about the cardio land. Because progressive cardiovascular care, implementing this and focusing on it in the home health setting is fairly new for all of us, we wanted to have some sort of group where everyone could come together and discuss and share knowledge, network with other agencies around the country. What worked for you? This hasn't worked for us. We've tried this. How are you addressing this? That type of stuff, that type of question. And also having direct access to the HHQI team. So we created something called the Cardio Land Learning Action Network. We meet once a month on the third Thursday. Our May meeting will be tomorrow, and it's actually a special meeting. A couple times a year, we normally have speakers come in and present on topics that are related to cardiovascular, and we've had some phenomenal speakers. I don't know how we've gotten so lucky, but we have. But tomorrow is one of the couple times of the year where it's peer learning. And so agencies will be talking about what their experiences are, what they've learned, what they would do if they had to do it over. So if you have not started, or even if you're a little ways into it, tomorrow's meeting is a really good one to start with. And don't worry, I know it's last minute if you weren't already participating in the Cardio Land, but it will be recorded and you can listen to it at a later date if you're not able to make it. This group is an invitation only, and I want to show you the milestones that you would progress through. I'll come back to the invitation in just a second. The cardio milestones, these are logos that you may already have seen from agencies around the country. Some are using these milestones. They're unique logos. You'll receive them every month based on what milestone that you have achieved or your agency has achieved, and you can use them in your marketing, in your signature lines, whatever you'd like to do. Then the other thing is, this is where I said it's invitation only, and so to join the Cardio Land, and the reason it's invitation only, it's not trying to be snobbish, it's just that HHQI has over 15,000 participants, and not all 15,000 are going to be interested in cardiovascular care. So we don't want to send them information on cardiovascular care if they are not interested in it. So that's why we try to be very respectful of the amount of emails we send out. And so for that reason, we only send Cardio Land information and invitations to those who are members of the Cardio Land. So to join, you go under the Cardiovascular Health tab, and you come to this page, and you'll see the great big blue arrow, and it says Join Now. The other thing that I wanted to share with you on this page is where you see the Join Now button. Once you click that, it will take you, well, it won't take you, but you will see your agency pop up in this interactive map, which is at the bottom of the page. I want to take a moment and mention this because this map is open to the public. And we have had upstream providers, meaning your referral sources, aware of this, and they have looked on this. One thing I didn't mention is the ABCS that we're talking about here. Those align with the physician reporting quality measures where physicians are required to meet. And by required, I mean they receive penalty by payment. They have their payments docked if they're not complying with those particular measures. This is not something that is specific to home health. This is how home health will align with what is going on in the community. Now, home health, totally voluntary. Okay, we're in a very luxury position right now in home health. We can do this if we want to, but physicians and hospitals are mandated to comply with those ABCSs. If their patients do not meet those measures at a certain percentage rate, they will receive a penalty payment, meaning that they will not receive their full payment. They're looking for partners, and we know this because agencies have contacted us and said, you have a map on your website, it has to do with blood pressure, I don't know what it is, but my agency is not on it, and I need on it. Well, this is how you get on this map. This is an interactive map, and it is open to the public. And like I said, it is being noted by some providers. We don't have a way of tracking who sees it, but we do know because the agencies have contacted us in a panic to get on it. Physicians are looking to align with agencies who are with the same goal. And if they realize that you're looking at the ABCSs and focusing on that as well, and that aligns with their current goals and focus, we can't say that referrals will increase, but we can say that at least they know that you're in alignment and they are aware of your agency. And there are tools in the BPIPs that include simple things like fact sheets. So if you are contacting the physician when you have a patient who has a history of a heart attack or a stroke, and they're not on aspirin or one of those antithrombotics, contacting the physician, very simple. Just contact them on the fact sheet, and that lets the physician know why you're asking, that you are focusing on the ABCSs. And if that physician is treating Medicare, Medicaid patients, they're going to be aware of it, at least of that measure, not aware that you're doing it, but they're going to be aware that that is a measure that they're in accordance with as well. So the Cardio Land, this is how you join, and this is where you will show, and every month and you'll receive an invitation. The last thing I wanted to share with you is something that we just started in January that was very hotly demanded, requested by agencies over the past few years, and we're just so happy to announce that HHQI University has been launched. This is the platform in which we are able to offer free continuing education to registered nurses. And it's not that we wanted to slight any of the other disciplines. It's just simply registered nurses have one national accrediting body, whereas the other disciplines, in order to offer CEUs or CEs at a national level, we would have to go to all 50 states and 4 territories to seek approval prior to publishing and awarding those. We're still working on it, but right now it is only offered to nurses. But every person who attends these courses will receive a certificate of attendance. And the topics align with this cardiovascular work. So as you're working with your clinicians, and you may be thinking of how to substitute, especially if you're going to use this as a coffee, as you are wanting to implement this into the home health setting, one way to promote buy-in is and to have your clinicians educated with what is current practices and make sure they're not practicing under guidelines from 10 and 15 years ago, is asking them to take these courses. Again, absolutely free, utilizes the resources on the website. Everyone will receive a certificate of attendance, so we wanted to just make sure you were aware of that. So with that, Andrea, if it's okay, I'll just go ahead and stop. I hope I didn't bore everybody to sleep, and just see what kinds of questions are out there. Oh, if it's okay, I'll go ahead and start with the chat box. I can see one there.
Yep, Katina, can you just let participants know how to queue up for questions?
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key.
Is it okay if I go ahead with the chat window?
Yes, please go ahead while we wait on people to queue up in the queue. Thank you.
Oh, no, thank you. Because I see the very first question I started at the bottom, and that is a fantastic question asking about why is warfarin not on the list for antithrombotics? It is the most common blood thinner in our area. Great question, and I say that it's a great question because it's exactly the same question I had. And all I can tell you is that the measures that you will see in the Home Health Cardiovascular Data Registry are exactly as they are seen in the physician reporting quality. And there are brilliant scientists and researchers who come up with this, and I've asked the question of them as well, and they said that warfarin is an anticoagulant, as well as, let's just go ahead with the others, which are heparin, and I don't want to mention trade names, but we all know that there's a few other anticoagulants that are used. And those are not frontline, whereas these others, the antithrombotics, are frontline. And when it comes to antithrombotics, there are 3 or 4 others in the country right now, but those have not been approved to meet this measure. So when you do go into the registry, you'll want to look at the parentheses. There are 4 other medications that are acceptable as a yes in place of aspirin, but that is it. And again, this is simply so that we can align with what the physicians are being held accountable for. So that's a really great question, and I thank you for that. And I realize that my answer is not as clear-cut as you would like. It's not as clear-cut as I would like. But the effectiveness and first-line treatment was something that is not there. But I will say that if you have a patient who has a history of an MI, and you call and they are not on an aspirin, but you do see that they are on warfarin as an example, when you contact the physician may say, no, they don't need to be on aspirin because they're on warfarin. Just a simple documentation in the clinician note or the physician note, wherever your agency decides to note that documentation, that would still allow that episode of care to pass in the registry. So you would not be dinged for that patient not being on aspirin or one of the 4 antithrombotics. So there wasn't an exclusion, if you will. The answers that you have to select from in the registry are either yes or no or contraindicated. So that would classify as a contraindication. There's one other question. If it's okay, I'll take this and then we'll stop for phone. I do not remember receiving a sign-in to the data access portal. There is first instructions on how to view the data part of HHQI. And HHQI, the data portal, you can absolutely, when you click login, you either have a unique login or you can, you'll be instructed to register. There's 2 things you can do. Under the data resources, there's something called Data Access Tutorial. It's a 15-minute webinar, and yes, we know 15 minutes how valuable that is, but I think you'll find it useful, and that will give you the steps on how to register for data access. And, of course, if you ever get stuck, you can contact us at HHQI. Our contact information is on the same page. And my contact information is at the end of this slide deck, so feel free to contact me as well. Andrea, that's all I see, unless I'm missing something.
Katina, do we have any questions in the queue?
We do not have any questions in queue for Cindy.
If it's okay with you, do you mind if I share one more tip that we've learned from agencies?
Sure, go ahead.
It comes down to the cholesterol question. Again, I don't know how your agencies are set up. I know how mine was, and there was no way I had cholesterol readings on any of my patients. Even if I collected the labs, it was likely it wasn't going to make it onto my patient records. What the agencies who have been successful in this have shared with us is that they've done it one of 2 ways. They have either made it part of the start of care when you're discussing with the physician after you've completed the start of care visit and you're discussing the plan of care with the physician, include in the orders to send the most recent lipid panel or make that part of the intake coordinator's responsibility. When they're requesting to have the order, the HMP, the face sheet, also the most recent lipid panel, just like that. And then it's in the record. Same thing goes for dual eligibility. Depending on your setup and how you want to do this, but most of the agencies who have been successful have shared with us, they have just made that part of the intake coordinator's responsibility or the start of care clinician in the sense of when asking for the order again and getting the face sheet, marking somewhere in the EHR or in your records where it's noted that the patient is dual eligible. Just a check mark in a box is all that's necessary as long as the clinicians can access that as well. So those are best practices, and that type of information is shared on the cardio land that come out and have come out because, again, this is all new for everyone. Just started in November. So we hope that you'll continue as you progress and learn things, share your best practices or your tips with other agencies as well. And we'll continue to share what we hear from the agencies that can help everybody.
Katina, do we have any questions in the queue at this time?
There are no questions in queue at this time.
All right, Cindy, if you don't have anything else to add, I don't see any other questions in the chat. I just want to thank Cindy for presenting for us and also thank everyone for joining us today for the Home Health Kickoff webinar. The slides will be available on our Lake Superior Quinn YouTube page within the next week. If you would like more information in Minnesota and Wisconsin, please contact Jerry Hineker in Minnesota or Ashley Green in Wisconsin, and I will put their information in the chat box. At this time, I would like to pull up some evaluation questions, and if you could please take a moment to let us know how we did by filling these out. And again, please be sure to join the CardioLand webinar, which is tomorrow at 2 p.m. Eastern Time. Again, thank you everyone for joining us.
Thank you all.
I would also like to say thank you, ladies and gentlemen, for joining. This completes your webinar. You may all disconnect, and I hope you have a great day.